Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined by Captain Noah McGilvery.
Hey, Chief.
Thanks for coming out to talk with us about another case. So this is a very unique case, and ultimately we're going to be talking about Myxedema coma, right? But that's, as we talk with Doc, is a $50 word that a lot of docs know, but it's not frequently seen or encountered. So really we want to focus on kind of the patient that you found and how it led us down that road to identify that that was the actual condition that she was dealing with. So very standard call. You're assigned to Engine 3. We know it's one of our ALS pumpers, and it was for a 17 alpha, obviously for a fall. And sounds like the notes that you all got was a female on the floor, can't get up, and you may have to force entry. Pretty general information, but talk with us a little bit about what you encountered when you got on scene and how it all developed.
Sure. I'm just going to back up a little bit and then kind of go back to when we were going to the call. We got the notes from dispatch, like you said, that you might have to force entry. So these calls can kind of be either, we get there, force entry, and we help the person up, or we force entry and they are deceased. So these calls can kind of range from nothing, public assist, all the way to a really sick patient. So I was on the way over there, I was thinking, about the best and the worst that could happen. When we got there, I told my crew, we grabbed all of our equipment as normal, and then we grabbed the irons. We ended up going up to the apartment. It sounds like the caretaker got on scene, was actually able to get a hold of an apartment manager or a maintenance person, and got the door open before we got there. So we ended up not having to force the door, went into the apartment and found the patient on her right side, very altered, lethargic, pretty much unconscious. It looked like she had some fecal emesis, and no radio pulses. So we pulled her out, started to assess her a little bit in the living room. Recognized right away that she's sick, upgraded 5.5, and then, kind of went from there.
All right. And it sounds like you had APD on scene because an ACS was also on scene because initially came in as a welfare check when it sounds like the caretaker wasn't making contact. Something didn't seem right. And then so you had a lot of resources there on scene, but you guys were basically the first medical contact.
That's true.
Okay. All right, so talk with us a little bit about your next course of treatment. So you had AAS coming, you upgraded them, you realized you're dealing with a very sick patient. Talk with us about what your assessment looks like to begin with that patient and some of the things that you and the crew did.
It always starts with the ABCs. Her airway, it looked like there was a little bit of dried fecal emesis, but there wasn't anything to really suction at the time. Her downtime, I'm not sure how long ago it was, but everything was pretty much dried around her mouth, so we didn't need to suction right away. Her respirations, they weren't markedly elevated. A little bit, it was maybe a little bit labored, but nothing, it didn't really, I don't really remember anything catching my eye about that. Went down the line to her circulation there. She had no radial pulses, barely had a carotid pulse, so right away, she had a profound amount of shock. So, from there, we just started, made sure we checked blood sugar to make sure that that's not causing altered mental status. Thought about some Narcan. It sounded like she had a history of meth use and not necessarily an opiate use. Her respirations weren't, on the lower side, so we opted to not do that. And then, finished it out, threw her on the monitor, got a 4 lead, a 12 lead right away. We noticed that she had a, prolonged QTC. Some of her T waves were a little bit peaked. And then we just, I was concerned about getting access for her profound amount of shock at that point.
Cold to the touch, warm to the touch, or pretty normal?
She was cold to the touch. Initially thinking back, I thought it was, had more to do with her levels of shock than necessarily related to the hypothyroidism and the hypothermia caused by that. But she was cold to the touch. I don't know if we ended up getting a temperature that was accurate on her, but she was cold.
And it's tough in that situation because you're really relying on historians. Was the caretaker able to give you anything else aside from the suspected use of methamphetamines?
She helped us gather the medication list. Sometimes we don't get a lot of help from the caretakers on scene, but fortunately she did a pretty good job. I think I handed my MDT to the driver so I could, start working on access, and then he, talked to the caretaker a little bit more, gathered a medication list, a little bit of a better history, and then we went from there.
All right. So it's painting the picture essentially of a patient who's possibly septic shock, right, is what we're seeing. Doc, what was unique about this case? And one of the key things that Cap mentioned was that he got that med list and he was able to see that the patient was on levothyroxine, which we know is for low thyroid or hypothyroidism. Why was that key in helping figure out exactly what was going on with this patient?
Yeah, I think the fact that you recognized you had a critically ill patient on your hands and you were doing all the right ABCs, making the right interventions to help stabilize her and sustain her life till she got to the hospital. I think it's so important that you took that extra second to try to find out a little bit more and get that med list, because I would suspect the fact that you passed on that the fact that she was on levothyroxine helped initiate that workup in the ER when she got there. Of course, she was still critically ill. And same thing as you, they were thinking, could this be sepsis? She got broad spectrum antibiotics, the full court press in terms of treatments. But they also added on those thyroid levels to check, and I think that was probably triggered by the fact that you got that med list. And interestingly, that thyroid level came back as 0, which I've never seen before, which helped lead to the diagnosis.
Oh, wow.
So,
and we talked about it a little bit earlier with the Myxedema coma. Another name for that is decompensated hypothyroidism. And what is that?
So it's basically just, I would suspect in this case it may be a combination of her not taking her medications with her substance use history, and then in addition, it's usually triggered by something else. So in this case, another infection. It just basically makes it where your thyroid is completely unable to keep up for whatever the reason might be. And it's interesting in this case, like you said, looking back on it, you're like, oh, now that makes sense, because she was so hypotensive, but she was so cold, and she wasn't ever tachycardic, which you would expect in someone who is shocky. Really that kind of, we call it like a paradoxical bradycardia, when you'd expect somebody to be tachycardic to compensate, and she wasn't. There's really only 2 types of shock that do that. One is neurogenic shock, because you've lost your sympathetic tone, and that's usually in a spinal cord injury and a trauma, or in this case with myxedema. And so the fact that she wasn't super tachycardic is telling. Either she was about to code, which was also quite possibly the case, or that thyroid hormone kind of drives your metabolism. And if you just don't have it present, then you're not going to be able to react like with a fever or with a high heart rate, or even with a clear mental status, which one of the hallmarks is altered mental status for this.
Interesting. So we got the 12 lead, we got O2 on board. We talked about fluids and you mentioned access. Was there difficulty with access, and how did you navigate that?
Yeah, we did have some difficulty. So it looked like I could, maybe get an AC IV started. That failed. A pretty good EJ presented itself, so I gave that a shot. That also failed. By that time, 5.5 showed up, and so we just decided, let's get going at this point. And then right when we got into the back of the ambulance there, did an IO and got access. We still had problems with that. I had good blood return and bone marrow aspiration, and then even after we put on the pressure bag, it still had some problems flowing. So we were trying to troubleshoot that. We had a really short transport time of 5-6 minutes. So by the time we did all that stuff, reassessed, tried to troubleshoot the IO, we were at the ED. So, moving on from that, I wanted to, try some fluids, and we talked about, at least giving maybe 500 mLs, and then if that's not making the condition better, moving on to a pressor at that point.
And I think that's a good thought. And in these critically ill patients where you can't get a blood pressure, there's no palpable radial pulse, you've got to at least give that perfusion a little bump. And if you don't get anywhere with your fluids, it's fine to start pressors a little earlier in these critically ill ones.
Likely no change in medication upon arrival at the hospital for you all. So you have a very critical patient that you all received in the ED. Talk to us a little bit about the treatment and the course for that patient when they arrive.
So our treatment and course is very similar to exactly what happens in the pre-hospital setting. It's always ABCs first. And so they had a little more hands, so to either troubleshoot the IO or get some more peripheral access to do fluids and pressors at the same time. But one of the key interventions in this myxedema coma with the severely low thyroid hormone circulating is to give steroids early. And I think that's where your med list came in very helpful here, is they recognized that in this severe of shock, gave her what we call high-dose steroids, and helped facilitate that path to her recovery. Eventually down the road, as labs start to trickle back and we get more information about what's going on, they found out that she had MRSA bacteremia, so she had a staph infection in her blood, which likely had been the underlying cause of this. And then also they were able to treat her. We can give peripheral thyroid hormone through an IV. So she was able to survive ultimately, which was shocking to me because I actually saw her when you brought her in, and I'm very surprised that she survived. She was critically ill. So.
And not only survived, but neurologically intact. It looks like the discharge is 10 days later.
Yeah, 10 days later, had the right treatments. The right things were started pretty immediately right out of the gate, and then replenished that thyroid hormone. And over the next couple of days, she started to wake up and become back to normal.
Great case. And I think it's one of those where it's a 17 alpha. It's a call we go to regularly, especially on the engines, and just taking that extra time to identifying how sick this patient was and jumping into action and recognizing that this was more than just a regular fall or just a failure to thrive. Like, this was a truly sick patient, and I think you guys took the steps to save her life ultimately. Any takeaways or pearls that you want to give to other, especially suppression officers, right? Because you're in a unique role where you're a paramedic, but you're also operating on a big red truck. And just in terms of calls like this or responding to these 17 alphas, these welfare checks, any pearls of wisdom that you can offer to those officers?
I think this kind of goes to say with anything, but not to become complacent with the coding on the call. Sometimes it's hard to just see these 17 alpha and not think, okay, I'm just going to go help this person up. Keep an open mind to what you're going to be exposed to when you get on scene, and then if you're presented with a serious patient, you need to jump in there, make sure you activate the correct resources. If you don't have an ambulance right around the corner, you need to get a rescue activated as quick as you can, and then do everything you can to prep that patient. You can do a lot on scene, even with the equipment we have on a BLS engine. We can get them on oxygen. We can manage the airway. We can manage, their breathing. We can start to, put them on the 4 lead, get a 12 lead, so that when an ALS provider shows up, they have the tools to really get started and work quickly. And then, another thing that's nice that I like to do is, especially on the ALS engine, is, sometimes I need to put my computer down and get hands-on with the patient, get in there, do IVs, manage the airway. And if you go over with your crew members, usually the driver of, this is how you work the computer, and they can be an asset so that they can gather more information while you're getting to work. That's worked out well for us. So utilizing all members of your team is a great a great thing to do.
Absolutely. Those are great pearls. And I think that obviously documentation is important. It's key. We focus on that, right? If you didn't write it down, it didn't happen. But ultimately, if the care that you're providing is inhibited by working on the documentation, then what's the point? So I think that's a great case. And I think, Doc, we talked about the fact that one extra step that Cap and his crew took was gathering the medication list, because even if you don't know, because I didn't know that the myxedema coma even existed, but just by giving all the information that you can through the historians to the physicians is helpful.
It's very helpful. So many times having that ability to be on the scene in someone's house where something happened, the things that you gather are so helpful, whether it's a med list or just a piece of the history or what you saw in terms of the injury patterns. It's all very important. So, and thanks for
Great work, Cap. I appreciate you taking the time to come out and talk to us about this case. That's all we have for today, but if there's any other interesting cases you want to bring forward, let us know. Give us a call. You can use the SharePoint tab. But until then, we'll see you next time. Thanks.